My name is Kian Kalp. I'm from the Melbourne Institute of Applied Economic and Social Research at the University of Melbourne. And I'm one of the Life Course Centre's CIs, and I'm also a node director at the University of Melbourne. So before starting, I would like to take a moment to acknowledge the traditional custodians of the lands on which we are all meeting today. For me, they are the Wurundjeri people of the Kulin Nation. I would like to pay my respects to the elders past, present and emerging. And I extend my respect to any Aboriginal or Torres Strait Islander people who are present here today. So it's my great pleasure to introduce Mary Alice, who is a PhD student in social policy at the London School of Economics. And she's speaking to us today from the UK, so it's really early for her, but we are really pleased that she's made the time to give the presentation at this time. In the afternoon for us. So her research is on social security policy with a focus on how the conditions and administrative rules placed on benefit recipients can impact child and young adult development. And she has done a lot of research already on using Australian data. Before beginning her PhD research, Mary Alice worked in economic policy and impact evaluation. And earlier this year, she has visited us in Melbourne and in Queensland, in Brisbane. And she's hoping to return for another visit by the end of the year. So today she will present her work on compounding disadvantage, health effects of an early life shock for Aboriginal children. The screen is yours, Mary Alice.
Great, thank you, Kian. And thanks everyone for coming. I'm very excited for the chance to present to you all. Before I begin, I too would like to acknowledge the traditional custodians, owners and custodianship of their land on which we meet today, and pay my respects to ancestors and their descendants. So this is a paper that's part of my PhD research looking at kind of longer term effects of an early life health shock. And I'll get into the details of what that health shock is in a few minutes. But just to kind of introduce you to this idea. So I should also say before I begin, this is joint work with Professor Stefanie Schurer at the University of Sydney. So the shock that I'm looking at today is something that we've done some research on initially. And we have research already that looks at this prenatal shock. So it happened during pregnancy for a cohort of children. And we have looked already at the impact of that shock on health at birth. So we know that there was this initial health shock that had an immediate impact on health at birth. What we're doing with this paper is trying to understand what happens later in life as a result of that same prenatal shock and shock to newborn health. So the question that we're trying to answer is, do we see longer term effects of that initial shock that affected health at birth? And if so, what are those effects? Why is it interesting? I think there are two reasons that make this kind of a general interesting question in addition to the kind of the question of the specific shock that we're talking about. And one of those reasons is just trying to understand more about how health at birth produces adult human capital or adult, health and education outcomes. So we have research already that's looked at quite a lot of detail into the impact of prenatal health and newborn health on cognitive skills in childhood. And we know that babies, for example, who were born with lower birth weight or who were born preterm tend to have, on average, slightly lower cognitive skills as measured by their test scores at school, for example. And we also know that early life health can have longer term impacts on adult health. So the first research that looked into this, that kind of began this idea of the fetal origins hypothesis of adult health, looked at the impact of low birth weight on chronic disease in adulthood and found that babies that are born with lower birth weight are more likely to have chronic diseases when they're older. So the question that I'm trying to answer with this research and to try and understand more about these mechanisms is to think about whether childhood health could be an intermediary between very early life health and these longer term outcomes. So to what extent is health explaining partly these cognitive skills and also these kind of longer term adult health outcomes? That's one question. The other question we're trying to look at with this research as well is what is the impact of a shock on Aboriginal children in remote communities in the Northern Territory? And the reason that that's interesting is because we know that there are different effects of shocks in different populations. And that's partly kind of drawing on this theory of compensatory advantage. This is Fabrizio Bernardi, who's a sociologist, has this theory that kind of bears out quite well in the data that, as you might expect, parents who are advantaged can pass this advantage on to their children. He talks mostly about education and how parents can pass on educational advantage to their children. But it's kind of this idea that having parents who have advantages means that they're able to help buffer their children from shocks that might otherwise have quite adverse outcomes on those children. And we know that there are kind of insulating effects of having parents with higher income and higher education. So the question we're looking at also with this research is specifically what's the impact of this shock for Aboriginal children in the Northern Territory who were affected by this particular health shock at birth. So the research question that we're looking at here is what is the impact of an in utero and early life health shock on children's health through to age 6, and specifically for Aboriginal children in Australia's Northern Territory. So looking at this question using administrative data, linked administrative data, and drawing on this exogenous policy shock that happened about 15 years ago in the Northern Territory. It's part of the Northern Territory intervention. And to give you a preview of the results, we find that hospital admissions for infection increased by about 1/3 of an admission per child on average. We see it concentrated in admissions for specific types of infections, so viral, bacterial, and respiratory infections. And that resulted in an average of 4.5 more days spent in hospital per child. So let me now give you a bit more context to that, kind of step back and show you what that shock is and how we got to these results. Okay, so what was the shock? So the shock was a change in the way that welfare was paid. You might know about this as income management, or more recently, the cashless debit card. So most people who receive welfare from the government, who receive unemployment benefits, parenting payments, other types of government transfers, will get all of their money sent to them as a cash transfer, and they can use it however they want. It goes into their bank account and they can just, take that out, spend it as cash, however they want to spend it. This was a change in the way people received their welfare benefits, so that half of the income that they got from the government was still sent as cash and they could use it however they wanted, but half of it was put onto this designated income management account, where the income was quarantined into this separate account managed by the Government Welfare Payments Agency, Centrelink, and there were conditions over what you could spend that money on. And specifically, it was supposed to be intended to be used for things that would benefit the family and children. So, spending on things like food, housing, fuel, and it could not be used for alcohol, tobacco, gambling, drugs, and porn. So if you tried to use the income for those things, then it would just be a block transaction. Okay, so that's the policy change. And you might be thinking, why is this? What makes this a health shock as opposed to just some change in policy that might affect some people and not others? Well, so this is a policy that came in as part of the Northern Territory intervention. And it was a change in the way that welfare was delivered, and it happened in 77 remote communities. The important thing that makes this a shock, though, is that it happened very quickly with a lot of challenges to implementation. So there were 3 months from the announcement of the policy to the implementation of the policy. And as you might imagine, with a policy change that's such a big change in the way that you receive your payments and the way that you can access it, there is a lot of infrastructure that needs to go behind that in terms of the payment system to pay people in the right way. And that, from what we can tell, didn't really happen that effectively. So we have quite a lot of information that documents these implementation challenges that recipients faced when they were trying to access their money. And we have some research that looks at the immediate effects of this policy change. Most notably for this research is this initial paper looking at the impact, as I told you before, on infant health. So we found that there was an 85-gram reduction in birth weight. and increased probability of low birth weight. So that's kind of what we're drawing on in this paper to build on that and say, okay, what happens next to that same cohort of children? And we also have some research from another part of the team who looked at the impact of this policy change on school attendance for older children, found that there was this large and temporary reduction in school attendance that lasted about 5 or 6 months and then went back to normal. Okay, and then to kind of get more into details of this, of why did this policy change worsen health? I think we can think about this in 2 ways. So one way could be that there was this change in policy implementation, and that implementation challenge led to these negative outcomes. And the other way we can think about it is in terms of the policy itself. So is there something about this particular income management policy that means that it does have these negative effects that could be ongoing, even after implementation has been sorted out? And I'd say, to kind of cut to the chase, it's a bit of both. So one of the issues, as you may be aware if you were following at the time, was the Suspension of Racial Discrimination Act when the policy came in. So this policy came in as part of the Northern Territory Emergency Response, or the NTER, and it led to a lot of people being disillusioned, resentful, and angry about this policy because it was racially targeted. There was also, as I said, a very short period between announcement and implementation. And we have a quote here from the review board of the policy of the NTER program. And they're saying people were required to master new, complex, and often changing procedures with a minimum of information or explanation. And this led to confusion and anxiety. So people having to learn a new way of managing their money in a very short amount of time. And also kind of in a more technical sense, the card payment infrastructure that lies behind being able to use these quarantined money for any specific purpose was not yet built at the time when the policy came in. So it took about a year for that payment infrastructure to be set up. And until then, it was a very manual system of like having to go to Centrelink, telling them how you want to spend your money, and then them having to send that money to your local store or to give you like gift vouchers for Woolworths or Coles or whatever, so that you're able to take that money and spend it on the essentials that you're supposed to spend it on. So it was a very manual and kind of cumbersome process in that first year. And we also know from the official evaluation report of this policy that there was quite a lot of people who couldn't access their money for some time. So we see that even a year after the policy rollout began, about 20% of funds that should have been quarantined and spent on essentials were not accessible by recipients. And that was because there were rules saying that if you didn't go to Centrelink and talk to them about how you're going to spend that money, then the money was withheld from you. So you couldn't access it until you actually went to an appointment and discussed it with a caseworker. And as you can imagine, living in remote communities, it can be quite difficult to get to those appointments. So those are kind of the implementation challenges that were, somewhat smoothed out over the first year, but there were still kind of some challenges that kept going. But there were also issues with the policy itself that were more long-term. So we know that a lot of the stores, for example, pharmacies and petrol stations, even in kind of larger towns and in Darwin, didn't accept quarantine money even years after the policy introduction began. So it meant that you were kind of restricted in where you were able to spend your quarantined money. And there's also some more recent research from Greg Marston at UQ and others who are in this team that looked at income management, finding that even current recipients, more than 10 years later, are facing similar challenges in terms of accessing their money and not being able to use their quarantined income at stores that sell essentials. And that leads to stress, anxiety, and difficulty paying for those essentials. So to kind of sum all of that up, we've got this policy that seems to be leading to stress and confusion, to income shortfalls, and to more difficulty in paying for essentials in terms of the logistics of just knowing, where you can go to do your shopping. And all of these things, we know that they can harm fetal development during pregnancy and infant health after birth. And there can be long-term consequences on child development of those initial shocks. So that's kind of a very long-winded way of saying this is why income management was a health shock. And we're looking at the impact of that initial health shock that occurred in a cohort of children during pregnancy and very early life, and seeing how that affects their development 5 or 6 years later. And this, as I said, is drawing on what's called the fetal origins hypothesis. And so the initial hypothesis was looking at the effect of prenatal health and experiences on adult health and earnings capacity. And there's been kind of more research that kind of tries to fill in these gaps, looking at this first step, which is what we've looked at initially, of the effect of prenatal experiences on health at birth, and then also looking at the kind of childhood health education as an intermediary between those earlier and later outcomes. So in this case, we're looking at the impact of this prenatal health shock on childhood health. And we're looking at specifically at exposure to this policy change during pregnancy, and also looking at what's called the 4th trimester, which is the first 3 months of life. And I think there's some emerging research that looks at the impact of not just the kind of in utero pregnancy period, but also those first 3 months of being quite key to children's development as well later in life. Okay, so getting into the methods of what we're actually doing in this paper. So we're using population-linked administrative data from the Northern Territory. This is Northern Territory government data, and we're linking together different data sets. So first, we're looking at women who were living in communities that were affected by this policy. So it wasn't all of the NT that had this policy introduced, it was just people who were living in Aboriginal communities, and there were 77 communities that were designated as part of this policy area. So we can look at the mother's place of residence at the time of birth to figure out if she was living in one of these communities or not. So we do that to kind of narrow down the sample of people who were just affected by this policy. And then we look at the birth records for all of the children who were born or who were in utero during that policy rollout period. And that happened between 2007, so mid-2007 and late 2008. So looking at children who were conceived from mid-2006 until early 2008. And that's a cohort of about 1,300 children. We also include a 1-year pre-rollout period to kind of help with the identification of the model. So we've got this cohort of children, and then we're linking that cohort of children who were born during this policy rollout period with their hospital admissions during childhood, so up to their 6th birthday. So we're looking at, as I say, primarily hospital admission. We also have some data that I'll show you later where we look at clinic visits, so GP clinics, but the main outcome we're looking at here is hospital admissions. The outcomes that I'm going to show you are kind of in 2 categories, looking both at whether the person was ever admitted to hospital for any of these reasons and the number of admissions to hospital. So we've got admissions to hospital for any reason, a number of admissions for any reason. We also have the number of days spent in hospital. And then we're kind of narrowing down to look at admissions for an infection. So we're looking at any type of infection, and then also these individual types of infections as well, to try to look at if there is an infection impact, then what is the impact on particular types of infection. The reason we're looking at infections in particular is that there is this kind of theoretical and medical link between poor prenatal health and having a weaker immune system. And there's quite a bit of kind of descriptive evidence that shows that there is this link in the data between children who were born with lower birth weight or who were born preterm with other complications and a higher risk of childhood infection. And it's also one of the top contributors to the burden of disease for children in Australia, and particularly for Aboriginal children. It's one of the leading cause for hospital admissions for Aboriginal children. And just to give you a sense of the kind of the magnitude of that, this graph is showing you the percent of children in the NT data who were admitted to hospital for an infection. So showing you 3 different groups of children. This orange bars, that's children who were born within these communities that are affected by this policy. That's the children who were in the that I'm going to show you. So this is children living in Aboriginal communities. Then we've got these kind of yellow bars, which is children who were Aboriginal, but not living in these communities, so mainly living in kind of the cities and towns of Northern Territory, mainly Darwin and Alice Springs. And then we've got non-Aboriginal children in the NT. So you can see that for children who are living in these NTR communities, about 2/3 are admitted to hospital for an infection at some point in their first 6 years of life. That's a very high share of people who were admitted to hospital for an infection. So it's one of these main reasons for hospital admission. And then another kind of methodological question is, how do we identify the effective income management and not other policies that came in around the same time? As I said, the what was called the Northern Territory Intervention, or the NTER, was a package of policies that were all coming in around 2007, 2008. But income management was just one of those package of policies. So what we're doing is we're using the fact that the policy was rolled out gradually to be able to identify the effect of this particular policy. And so you can think about it in terms of there being, up to about 80 communities. I'm showing you just 2 here, but think about there being, 80 of these. And each community got it on a different date. And so you can look at kind of the quasi-control and treatment group being those who had the policy earlier, being treated earlier, and those who had it later being used as the control group for those communities that got it earlier. So the policy came in over a period of about 13 months. And this graph shows you the distribution of rollout dates. So you can see that it was quite gradual over this period, with more and more communities having the policy as we go over time. And the rollout schedule was, I'm going to kind of tell you this, and I can show you some evidence of this if you don't believe me, but I'll just tell you this and then you can ask questions if you have any. So it was as good as random. And by that, I mean that we saw a different timing for the policy introduction of income management than any other type of policy that came in as part of the NTER. So they were all introduced on different timeframes. In particular, income management came out, as you can see, quite gradually, whereas other policies that were part of the NTER either came out kind of all together in all communities at the same date, or were much slower in being implemented. And we don't see any link between pre-treatment trends in childhood health and the timing of the rollout, and no systematic kind of geographical link that we can see. So if you look at a map of when the policy came in different areas, it doesn't look like that there's any kind of systematic link between, for example, doing it first in larger communities and then smaller communities and kind of going out more gradually geographically. It sort of looks quite random. And then we do test this econometrically. That I've got this test here. I won't go into it unless there are questions about that. Okay, and the estimation method that we're using is what's called just a generalized difference in difference based on this gradual exogenous rollout. Anyone who's kind of in this literature might know that there's been quite a bit of discussions in terms of how to estimate these models in the past couple of years. We're using an estimator that uses the imputation from Borusaki, Aravel, and Spies. So if you have questions about that, then please do ask, but otherwise I'll just kind of skip over the methodological details. So what we're doing here is we've got a treatment group and our comparison group. Our treatment group is children who were exposed to the policy shock either during pregnancy or in their first 3 months of life. And the comparison group is those who were exposed to the shock at 3 months of age or older. So the important thing here is that we're looking at children who were all exposed to this policy shock at some point. And the difference is in the timing and whether the timing happened during what's thought to be this key developmental period of pregnancy in the first 3 months of life. We're using in the model some community fixed effects. So we're looking at controlling for the community where the mother was living at the time of birth, and time fixed effects being the quarter and year of birth. We've also got controls in the model for the sex of the baby, the mother's age, whether it's the mother's first pregnancy, the season of conception, and rainfall in the first 3 months, in the 3 months leading up to the birth. Okay, so getting into the results now. So this first graph is showing you an event study where we're looking at the policy's impact on the number of days spent in hospital from ages 0 to 5, so up to their 6th birthday. And so you can see here that for children who were exposed to the policy from 3 months or older, we don't seem to see any kind of differences over time. But for those who were exposed during pregnancy or in their first 3 months of life, we do seem to see a higher number of days spent in hospital. So it looks like there's kind of a bit less than between 3 and 5 additional days spent in hospital, depending on the timing of the policy introduction relative to the baby's date of birth. So that's kind of our headline result, but it looks like there is this impact on the number of days spent in hospital. And to kind of put that in numbers, this table is showing you that same model, but looking at it just before and after instead of looking at it kind of split into those quarters. So here we've got number of days spent in hospital, and it's about 4.5 additional days per child. But we haven't got any significant impact on hospital admissions in total. So if we look at just whether ever admitted to hospital and looking at number of admissions to hospital, we don't see any effect there. But we do seem to see an effect on admissions for an infection in particular. So we're seeing about 1/3 additional hospital admission for an infection per child. And then, so that's kind of our impact on infections in total, looking at different types of infections. So we're breaking it down into these different types of viral, bacterial, respiratory, soft tissue being kind of skin conditions, gastro and genitourinary. We are seeing an effect on viral, bacterial and respiratory infections. And it looks like this is coming through children who, so the effects between kind of number and ever admitted are very similar. So to me, that says that it's children who perhaps have been in hospital for other types of infections already. So there's not this kind of headline effect on whether ever admitted for an infection, but we do see impacts on these particular types of infections. Okay, so that's kind of the main result that I'm going to show you, but I also want to talk through some additional results. I'm not going to get through all of this, but just to kind of tell you that we're looking at, I think these first two ones, the ones that I want to cover if we've got time. So looking at are children actually less healthy if they're going to hospital? And we can look at primary care visits to be able to get at that a little bit. And we can also think about, could we have predicted these kind of longer or sort of medium-term health outcomes from having information on health around the time of birth? There's also a range of robustness tests that I won't get into unless there are questions about those. Okay, so first off, do more hospital admissions mean worse health? So it could instead be a change in care-seeking behaviour that's leading to this change in hospital admissions without any underlying change in health. So it could be that more hospital admissions might mean that children are going to hospital instead of going to primary care. So they're going to hospital instead of just going to the GP for any kind of minor infection. Or it could be that children and their families are avoiding primary care, leading to untreated infections that become more serious. And then longer term, they require hospital admissions for kind of acute care for that infection that could have been prevented if it had been treated early. So we can test this with clinic data. So looking at primary care, so GP visits. If the treatment group have more clinic visits for an infection, then that kind of adds to the evidence that this is indeed children being less healthy, not that they're just kind of going to hospital instead of going to the GP. But a caveat with this analysis is that we have clinic data available for about 2/3 of communities, and not every community has a clinic. And we only have it from 2010 onwards, so from children being about age 3 within this cohort. So we've got a limited sample of children that we can look at for this clinic data, so we haven't got a full picture. But that said, here's what we find. So this is again looking at any consultations and then number of consultations. And it looks like we've got about 1 additional clinic visit per child as a result of this policy change. So we go from 5 1/3 clinic visits in the first, between ages 3 and 5 to 6 1/3. And again, it's kind of difficult to say with this small sample, but it looks like we're seeing this primarily coming through these 2 types of infections, being eye or skin infections and respiratory infections. That to me is kind of additional evidence that this is not just a change in care-seeking behavior, but it's an underlying change in the number of infections that children are having. Okay, and then just quickly on thinking about this in terms of what I'm going to call mediation analysis. This is a very simple analysis, but it's kind of trying to get at this idea of, could we have predicted this earlier? So we had this shock and look at the impact on childhood health. And we can think about, are there intermediaries that would help to explain what happened to childhood health. So that we can think about this indirect effect of the shock, intermediary, and then childhood health, or we can think about the direct effect of the shock just on childhood health without the intermediary. And the kind of obvious one is that we already have this impact that we had measured earlier looking at birth weight. So could we have predicted from the initial impact on birth weight, these longer term impacts on childhood health? And I'm going to look at a bunch of different potential mediators, looking at kind of these antenatal health and care outcomes, and then also looking at health in the first 3 months of life. So looking at admissions for an infection or for other reasons in the first 3 months of life, and how well does that predict these longer term health outcomes. And here's what we find. Apologies, this is a bit of a large table to absorb in a small amount of time, but just to kind of step you through what we've got here. So these are two of these main outcomes that I've showed you before. So days spent in hospital and number of admissions for an infection. And the mediators are going to be each of these rows. So looking at the mediator being birth weight, we're seeing total effect, as I showed you before, about 4.5 additional admissions per child on average, additional days spent in hospital. And the direct effect, so that's the effect without taking out the effect on birth weight, is quite large. So that's just over 4 days in hospital. And that leaves about 10% of the impact of the policy change on days in hospital that's mediated through birth weight. So that's kind of saying that a relatively small amount of this impact appears to come through that channel of birth weight. So then that kind of leads to the question of what else could we look at to be able to look at kind of what could have helped us to predict this outcome earlier. And just throwing in all of these potential explanations together and adding them to this kind of model all combined together, then we can see that from all of these, we can kind of explain or mediate about 50% of the impact on days in hospital and 80% of the impact on number of admissions for an infection at all. And that kind of, I think that's quite interesting because although this is kind of very exploratory, it's showing us that there are these measures that we could have looked at in the first 3 months of life and during pregnancy and birth that would help us to kind of predict this longer term impact. Okay, so let me kind of get to the end and conclude. So I'm going to tell you first about policy implications about income management in particular, and then some more general conclusions. So in terms of policy implications, we're seeing a double burden of this policy because we've got a cost to children's health that I've showed you in these results. We've also got a cost to the public healthcare system because we're seeing more admissions per child. I estimate based on the number of nights spent in hospital, that's about a $4 million increase in hospital costs because of this policy change. And then thinking about, are we likely to see these same impacts in more recent birth cohorts that have been affected by the same policies of income management and the cashless debit card? I'd say there's kind of mixed evidence, but we might see similar but smaller effects. In that this policy implementation period was a very unique situation. It was the first implementation of this policy, and it has since been rolled out more kind of broadly and with fewer glitches, but there are still these kind of glitches that we hear about over time. So current recipients are still facing some of these issues that lead to stress, anxiety, and difficulty paying for essentials. And that could mean that we have these same mechanisms at play that might be having kind of the similar but more modest effects on children's health. And then more generally, we're finding that this in utero and fourth trimester exposure to a shock worsen childhood health to age 6. We're seeing increased rates of hospital admissions for infection and 4.5 more days spent in hospital. So to get to that kind of broader question of do shocks that affect health at birth also affect childhood health? I'd say yes. In this example, it seems like that is the case. And much of the effect that we're seeing was not evident in standard measures of health at birth. So standard measures being kind of birth weight and preterm birth, low birth weight. We had a lot of the mediating effect coming through other variables and not through those kind of standard measures. So a child who has no measurable impact at birth on those kind of standard measures might still be experiencing long-term health effects from exposure to a shock in pregnancy or in very early life. And that can help to explain potentially longer term effects that we see of in utero shocks on education and adult health in other research. And I'd also just add that these effects are large and that might reflect the limited ability for parents in this context to be able to make investments that buffer children from those initial health shocks. Okay, so that's it. Any questions, then please do ask now, or if you have, get in touch, then my email address is here and Stephanie's is here as well. Thanks very much. I'm looking forward to your questions.
Maybe I'll start off with one question and others can follow. So I was really interested in your mediation analysis. I thought that was really quite a strong component. I mean, 50% and 80% that can be explained by sort of the various mediation factors that you included. And so one thing I was wondering about was, have you thought about the policy implications of that? Is there anything you can do with sort of this knowledge that you have at, I guess, at 0 to 3 months about the health of the children that can sort of, I guess, prevent some of sort of the following health shocks that occur?
Yeah, that's a really good question. And I'm not totally sure. So I think I'd say that I agree. It's like super interesting to look at the mediation analysis, but what I call mediation analysis here is very simple compared to the way that it's done in other research. I wasn't able to do kind of the more fancy methods because I was combining it with this difference in difference estimation that's that you can't combine with other types of mediation analysis. So I'd be a bit cautious about these results in terms of like assigning much of a causal interpretation to them, and it's more just like trying to look at the predictive effects of those variables. And even then, it's kind of, I think it's sort of a data mining exercise more than something that we can like really necessarily draw strong conclusions from. But yeah, I mean, I guess it's difficult to know if we're looking at something that could be prevented in terms of like, if we can look at children in their first 3 months of life and look at all these indicators, then can we provide treatment that would help to buffer them from those longer term effects of shocks? And I think from other research that I've seen, it seems like it's possible to do that, at least on other health outcomes. So I think there must be, something that you can do. I don't know what that would be. But also it could just be that there's like just knowing which are the children who are going to be most affected by these health shocks and being able to kind of monitor those children and make sure that they get earlier care could be kind of one implication of it. But yeah, I think in terms of like what to do with the information, I'm not totally sure.
Thanks, Mary-Alice. I think there's some questions in the chat that have appeared. So maybe start with the one from Jack about the question about the info, whether there's any info and or interest in the presence or absence of siblings and perhaps affect modification. I don't know if you want to further clarify that, Jack, or whether it's totally clear, Mary-Alice.
Thanks for the question, Jack. So I could actually look at that. So because we have this linked data, we can link based on the mother and be able to look at the child siblings. I haven't done that yet, but it's definitely possible to do. So looking at it in terms of like whether having a sibling would be important. I think so. One thing that I thought about in kind of a similar vein is potentially catching an infection from an older sibling, because if they're going to childcare and you're a baby, then maybe you kind of get the same germs that the sibling is bringing home from childcare or from school. So I think that's possibly a channel that could partly be part of, like, it could be some other exogenous shock to people's like catching an infection, and it could also have other effects that I think you're suggesting here in terms of just the presence of the sibling, and that might be having effects on the family's investments that the parents can make. yeah, good question, but I haven't looked at that, and that's something I can definitely do with the data that I have. So thank you.
Just looking, so there is one relatively extensive question around robustness check for change in the grouping window. If you would change 0 to 3 months to, for example, 0 to 4 months, whether that makes a difference. Is that one of your robustness checks?
So thank you for the question, Peter. I haven't looked at this in that way in particular. So I think like one way to think about this is in terms of just looking at this, like these event study graphs, and you can see that if you look at, 4 to 6 versus 0 to 3, there doesn't to be a difference here. But in terms of like, if I change this to 0 to 4 or 0 to 2, I haven't looked at that. So I could look at that to try and be a bit more precise about when this effect seems to start to emerge. I think probably it's kind of a more gradual thing. And I'm not sure if we'd see much difference. We looked at 0 to 4 or 0 to 2. Yeah, that's a good question. I think it's always difficult to try and be more precise about this, and even to break this into trimesters and be able to say something about, oh, the effect in the first trimester is larger. It seems like maybe it is larger here, but the confidence intervals are so wide. So yeah, it's difficult to know if the differences that we're seeing here that we might see if we looked at kind of different definitions of this cutoff, if it would be kind of a meaningful difference, or if it's just kind of noise in like a relatively small sample. So yeah, good question. I'm not sure if I had the best idea to be able to answer that, just because it's a relatively small sample and trying to do a lot with it, looking at these different kind of periods of exposure, I think is probably stretching the limits of what we can do with about 1,000 observations.
I think there was another question in the chat from Kevin about getting profiling of inflammatory markers, given how much work there is on infection.
Hi, it's not really a question exactly. I've just, there's people at Telethon Kids Institute who do a lot of work around the development of inflammation, and there's a lot of work around early life stress, dysregulated immune system functioning and coming out of utero. So it's just one of those areas that I'm interested in, and just seeing the data around infection being the key thing accounting for the mediation makes me think, there's a cross-disciplinary study that needs to happen there somewhere. But it's not a question, just a comment. Thanks.
That's very helpful. Thank you, Kevin. I didn't know about that work. I'll look it up. Thank you.
Okay, there's also a question from Martin, and he said, without knowing the history of this in detail, is there any evidence that income management succeeded in reducing alcohol consumption or smoking in pregnancy? And are there any offsetting pathways that might operate differently in different contexts?
Thanks, Martin. That's also a good question, one that's very difficult to answer, because there's been so many evaluation reports of this policy and of these different kind of formats of income management and the cashless debit card, but very difficult to kind of say anything about the impacts on alcohol and tobacco or other kind of vices, I suppose. Also kind of the narrative around drugs and illegal drugs, and that's where they were limiting cash exposure. I think, so what has been done in the kind of official government evaluation reports, they've done surveys of people in communities who were affected, and have kind of surveys have said that people feel that there's been a reduction in alcohol and tobacco consumption. But those surveys are quite small. And I think maybe you can imagine if you're being surveyed by someone who's coming to test a government policy, then maybe you would not necessarily say that there's been no impact on alcohol, or you might kind of say, oh yes, it's all worked, thanks for the help, or something like that. I'm not sure. So I think those official reports are kind of difficult to interpret, and to know if those results that are reported in those reports are really reflecting reality. What we do have is, so in the birth records that we've got here, This is again kind of problematic data, but we do have information on whether the mother reported that she was smoking or drinking at her first antenatal visit. And so we can look at that to see if the mother is at least reporting that she's smoking or drinking less, and we find that there's no effect there. So to the extent that data is reliable, it seems like there's no immediate effect on alcohol and tobacco consumption, at least for pregnant women. But again, it's difficult to know if that's really what's going on. Another way that we can look at it is looking at kind of expenditure data from like the ABS expenditure surveys. And that also shows that there's been kind of really no difference in spending, and also that spending on alcohol and tobacco was already quite low to begin with. But that is also difficult to be able to interpret because, you know, if you were spending money on alcohol and tobacco, a lot of your income on it, then perhaps you wouldn't report it to the ABS. So I don't know. So I think these things are very difficult to have any data on. Best evidence that we have is that there's been not really any significant impact, but it's difficult to say. I think that, so this point about people attriting or moving away from the area due to the policy, I think to some extent this was prevented because it was based on where you were living at the beginning of the policy rollout period. So it would have been like, even if you moved somewhere else during the period, then you would still be affected by the policy in the community that you were living in. So that kind of meant that wherever you go, you're still covered by it, unless you're like really moving out of the area permanently, like you're moving interstate or something, then you might be able to get an exemption. And your question again about like whether it's worth it, I personally would say no, but that's just my opinion. I think it's difficult to really, so there's been all of these claims of kind of benefits of this policy, not just in Northern Territory, but more broadly. To me, there's really not a lot of evidence that any of those benefits really exist, but that's also just my opinion. And it's difficult to interpret all the information that we have from various government reports and other evaluation reports because it's all kind of looking at different outcomes and different time periods. So I think in terms of having kind of a general answer of the policy's impact, it's still very difficult to say.
I was going to just follow up on that. So have people looked at police records? So would there be sort of any information on sort of, I guess, disturbances that were sort of fueled by alcohol? I mean, that would be maybe an official report that could sort of be seen as more independent. Have people sort of tried that, or is that also very difficult to assess?
Yeah, I'd say also difficult, particularly in Northern Territory, because when the policy came in, there was also at the same time an increase in policing. So we've looked at trying to get this data and haven't been able to get access to that would break down police reports in that way to be able to even look at that. I've looked at it in Queensland for the trial site there and don't seem to find any effect on police. Perhaps there's even an increase in police call-outs. But again, it's difficult to know if that's happening because the policy is coming in at the same time as increased policing or changing in policing habits. So from what we can see, there's no impact, but again, hard to know because it's a noisy indicator.
I was a little bit curious about whether, so you talked about the shock for, obviously you're focusing on Aboriginal children, and I was wondering if you would expect the shock to work in a similar way for non-Aboriginal children. Like if you can hypothesize on like kind of why you wouldn't expect a similar or different shock. And then I just had a question about the rainfall I think it was rainfall at birth, what that indicator was for.
Mm-hmm. Yeah, so I think, well, I'd say that perhaps the impact would be larger for Aboriginal children, just because we're looking at these like very remote disadvantaged communities where people have kind of limited access to fresh food and healthcare. So that might mean that we see kind of worse effects of any shock that might affect someone during pregnancy because they're not able to kind of buffer that with better care and better nutrition. But yeah, so I'd say probably it's going to be a larger effect in these communities, but it'd be great to be able to look at this in more detail, to look at other cohorts to see if that's the case. And then, so the use of rainfall as one of the controls. Great question. I actually have a paper about this that I've looked at separately to try and look at the impact of seasonal patterns on birth outcomes in the Northern Territory, to try and kind of disentangle the effect of this policy change and that kind of being implemented over a year, and be able to look at kind of the effects of different months, and then the kind of general seasonal pattern in birth outcomes. We do see a very strong seasonal pattern in the Northern Territory. And so what I'm doing with that control for rainfall is to just like try and disentangle the effect of kind of that regular seasonal pattern versus the policy's effect. So generally, babies that are born in the summer or the wet season have worse health outcomes. They're substantially likely to be born preterm and with lower birth weight, lower APGAR scores. And so that rainfall control is trying to just like pick up the fact of that seasonal pattern, and the fact that it can change from year to year in terms of when kind of the monsoon season starts, and that being different in different years. And so having that control that looks at just rainfall in the past few months, instead of looking at kind of those month effects that could be different in different years.
I would like to take this opportunity to thank you, Mary Alice, for your very clear presentation and for answering all our questions. I really get a sense of a research project that has been very carefully carried out. Look forward to further studies that I'm sure are going to appear from you and your co-authors. I would also like to thank the audience for participating today and asking interesting questions. I also like to sort of let you know that there will be more life course centers in 2022, which will be featured on the LCC website. A recording of seminars is usually made available within a week or two. So, and I think that will then be emailed to the LCC members. Next seminar has just been pinned down and will occur on the 26th of May and will be presented by Professor Nick Closure. If you are interested in presenting at a future LCC seminar, then please feel free to contact either Rennie Lee or Nancy Kong. I'm sure they will be very happy to organize and schedule your participation. But for now, thanks everyone and goodbye. See you next time.